Good morning. My name is Sheeraz Siddiqui. I'm a general surgeon working at the Indus Hospital, and on behalf of the organizers, ICON 2022, I welcome you to this general surgery session. The main theme, coping with change, primarily reflects the challenges of the past 2 years, which have been seen in almost every walk of life. And in this context, we dedicate our session to the resilience and steadfastness of the medical fraternity in general and the frontline responders in particular. We have 7 free papers spanning across a wide spectrum of the surgical practice. The hallmark is that more than half of the original researches have been conducted by junior level trainees, those initiated into the discipline at the very height of the pandemic. And this in itself is a significant reality where the future of general surgery will be dominated by the generation which was baptized into and probably most affected by the pandemic. In this context, one of the biggest challenges of a training program like ourselves has been on how to continue to impart comprehensive training, especially the operative workload when it comes to a surgical discipline during the pandemic. And this happens to be the first topic of our session to be presented by Dr. Ghina S Shamsi, who is both the head of Department of General Surgery at the Indus Hospital, as well as the chair of Postgraduate Medical Education Department of the Institute. Dr. Ghina S Shamsi.
Presenting on a very important topic, which is pandemic and surgical training. When 2 years back in 2019, COVID hit worldwide, we were still awaiting the results of what will happen to us. Early 2020 saw majority of the hospitals going into a lockdown position and basically just catering to COVID and COVID related illnesses. This created a big gap for all the people who were in the training program. So what I'll be presenting is an overview of all the literature which is present and focuses on how the surgical training has been impacted by the pandemic. So the impact of COVID-19 on surgical practice is widespread. It's not only about, we're not only talking about the issues which happened earlier on, but what the sequel is there. We have an impact of surgical education and training along with the surgical burden of the diseases. How my surgical practices have gone through a full circle from being into a complete stop to a current scenario requiring additional workforce to balance the backlog. The increased burden in presence of a 2-year lag, along with the fact that we have very undertrained surgical trainees. I mean, all those residents who started their training back in 2019 or 2020 have not been able to attain their surgical skills up to the marks that they can help in the surgical management of patients to the extent. And this is creating a big void. What has happened? There's reduced outpatient clinic, ward work, multidisciplinary meetings, everything that was required to shape the future of the young surgeons were not present. The two major groups of trainees which were badly affected were either the young ones who have recently started their trainings and they did not have any exposure to the early years, the meetings, because of the cancellation of elective surgeries, redeployment. And the other was the most senior lot. Those who were nearing the end, they never got the share, the lion's share, as we call it, in the final years. I mean, nearly 12% of those nearing the end of training are delayed due to COVID-19. Their annual reviews shows there's a lack of competency progression, and we cannot blame them for it. The current cohort of senior trainees, which require an extension of training, or we need to deploy a method to give them the required exposure as seniors. So I'll be focusing on the areas which, how the training has been affected and what can be done to annul the effects. Theater exposure. Now, in the first wave, there was more than 50% reduction of all the emergency cases. Elective cases were all cancelled, and plus extra work to take the patient to the theater. I mean, now if an emergency comes, now we need to make sure that there is no COVID, the COVID test is sent. If it's not sent and the report is not there, then the extra man hours and extra effort to create an environment with the transmission is reduced. This all has caused a reduced workflow. And the COVID-19 free surgical pathways have now been established, but they're still in a very early phase. The other impact was on laparoscopic surgeries. Now, laparoscopic surgeries were seen as aerosol producing, generating procedures, and thus either discontinued completely or reduced, thus causing a very less significant exposure, especially for the new trainees, but also on the senior resident who missed out acing their competencies. Parkwell et al. Conducted an international survey assessing the impact of COVID-19 on endoscopic training. And 93.8% out of 770 respondents reported a reduction in endoscopy case volumes, with a median percent of reduction up to 99%. Now, that is a great impact. Somebody who is on the final year would be aiming to get at least 100 endoscopies done in a year. Now will only be able to get 20. So their experience, their exposure is much reduced. The training opportunity reduced not only during the pandemic, but also in the recovery phase as well. Now, as we face the next wave, we still are at loss in how to cope it up. The other was the outpatient clinic. The outpatient clinic were either cancelled or converted from face-to-face to virtual consultation. Now, what did it mean for a young trainee? A young trainee was deprived of outpatient supervised clinics, limited exposure, case discussions. Though many authors have found an advantage in virtual clinics and accrediting them for continuing outpatient clinics in future, even when the pandemic has settled down, a meta-analysis by Chaudhary et al., which included 12 studies, 8 of which were randomized controlled trials, compared surgeon-patient satisfaction with face-to-face and virtual clinics, found no statistical difference in surgeon satisfaction or in patient-reported clinical outcomes. I would recommend inclusion of telemedicine in a revised curricula, but we cannot exclude the human factor. The aspect of examination cannot be present in a virtual clinic. You have to have the feel. You have to have these encounters in the clinic not only allows the students to learn how to communicate with the patient, but also how to manage a patient, how to manage himself in the presence of an awkward situation, how to break a bad news with one-on-one perspective. So all that has been missing out. The third major issues was there were teaching sessions which were canceled, the training courses and seminar. For infection control measure, reduce large gatherings, training sessions, even ICON has now become virtual. And either these were postponed or there was a lack of communication. Things went onto virtual platform. A lot of people, like the global survey conducted by Yazadami et al., the trainees expressed a relative dissatisfaction with virtual platforms because there's no human touch to it. And the learning is challenged. The amount of attention span is challenged. The conference presentation do not only gives young surgeons a career, a chance to showcase, but also career progression. It helps them come up with their public speaking and presentation skills, and that becomes an integral part of their job application when they're done. So if by taking that out of the equation, the overall experience of being a surgical trainee is vastly reduced. So for every action, there is a reaction. The pandemic has forced both trainees and trainers out of their comfort zone, yes. But what has happened? We have now technology to help us in advanced learning. We use If not virtual, we're using immersive technology, that is virtual reality, augmented reality, and mixed reality to teach complicated clinical situation. The modern additive technology like 3D reconstruction, CT, and MR increases the teaching fidelity. Similarly, enabling the methods made by cadaveric stimulation makes cadaveric storage and making them reusable, thus allowing them to learn on cadavers. The situation is dangerous. And if we do not take it seriously, and this is the high time that we learn how to change the curricula. If we do not train today, we will have no surgeons tomorrow. Thank you.
Thank you, Dr. Ghina. One only hopes that the effects one will be able to reverse the effects of the deficiencies that the trainees of the past 2 years have faced over the next coming years as the pandemic hopefully dwindles down to naught. I think it'll be prudent to gather up the questions and have a question answer session towards the end. So we'll move on to the next presentation. A significant volume of malignancies are being dealt with at our institution, and colorectal cancer, like any tertiary care or cancer care institute, forms a major portion of that volume. Dr. Nazia Lodhi is a consultant general surgeon working at the Indus Hospital. She also happens to have a special interest in surgical oncology. She'll be presenting on this unique topic of the rising incidence of colorectal cancer in the young. Dr. Nazia Lodhi.
I am Dr. Nazia Lodhi, consultant general surgeon in Indus Hospital General Surgery Department. Today, I am discussing the very hot topic, the rising incidence of early onset colorectal cancer. Early onset colorectal cancer, it's defined as diagnosed cancer occurring in individual under the current recommended screening age of 50. Is this a coincidence, or is adult colorectal cancer is a rare epidemic? We are facing early rectal cancer and advanced stage early rectal cancer more frequently in last 2-3 years. So we are decided to choose this topic, and we did a cross-sectional study at Indus Hospital, and we collect data of general surgery department from Feb 2021 to September 2021, the 8-month data, in which we found 52 cases of colorectal cancer, in which 30 are the male and 22 are female patients. The age ranges from 16 to 70 years of age, in which 29 patients are less than 50 years and 23 patients were more than 50 years. And the tumor site, the colon cancers are 15 in number and rectal cancer 37 in number, in which rectal cancer less than 50 were 24 and in colon cancer less than 50 were 5. And the tumor histopathology showed that in 15 colon cancer, 8 were moderately differentiated and 1 were poorly differentiated cancer. And in rectal cancer, there were 37 in number, and moderately differentiated cancer were 18 and poorly differentiated cancer were 10. And we found a carcinomatosis in 14 patients, in which 4 were colonic cancer and 9 were rectal cancer. And now the management of the patient, we did curative resection in colonic cancer in 3 patients who were less than 50 year of age, and curative resection of colonic cancer in more than 50 patient, 50 year of patient were 8. And in rectal cancer, the 13 less than 50%, 50 year of patient, 13 were in 13 patient we did curative resection, and 11 patient we did palliative resection, palliative surgery. So the rectal cancer in young patient showed uh, very aggressive disease, mostly in rectal cancer and in early age. And in the so we see the stage of the tumor, in which the stage 3 and 4 were more, and stage 3 patients were 35, in which 25 patients were rectal cancer and 10 were uh, uh, colonic cancer. And in rectal cancer, less than 50 were 15, and in colonic cancer, less than 15 were 2. And in stage 4 disease, there were total 8 cancers, in which 6 were rectal cancer. And in rectal cancer, less than from 6 less than 50 were 5 in number. So they present with more aggressive disease, stage wise also. And in immunohistochemistry, were markers which were positive in colonic cancer, chromogranin, CK20, CDX2, CK7, and STAT. And in rectal cancer, these were the immunohistochemistry which were positive. But we did immunohistochemistry in limited number of cases according to histopathology. So, before starting the incidence, this was our study in which we found a more aggressive stage of the tumor and more number of patients which were present in early stage of disease, and the disease were aggressive, and we did mostly in palliative surgery, and the prognosis was poor in these patients. We didn't show the data of the mortality or the recurrence because it's a short time, or a cross-sectional study. So the long-term result we didn't show in our study. So let's talk about the worldwide incidence. The colorectal cancer remained the third most incident and the fatal cancer in all age group and in both women and the men. Annually, over the past 4 decades, for colon cancer, the adjusted incidence rate have increased by 2.4% in those aged 20 to 29 years of age, and it's also increasing from the age of 20 to 49 year of age, but more in 20 to 29 years. And for rectal cancer, it was increased to 3.2% in those who are in age group of 20 to 39 years. And in 2.3% in those who are in age group of 40 to 49 years of age. Giving the projection of current incidence rate to the year 2030, the largest predicted increase in colon cancer 90%, rectal cancer 124% cancer incidence will occur in 20 to 34 year of age group. So it is very high. So we need to find a solution to decrease this incidence in future. The incidence rate of both colon and the rectal cancer will decrease by 41 to 41.1% respectively in the older age group more than 50 years of age. Hereditary polyposis. Colorectal cancer is the most common form of hereditary rectal cancer, which accounts for 2 to 5% of all colorectal carcinomas. Sporadic cancer also occur, which account approximately 70% of early onset colorectal cancer, significantly exceeding the that of general population. The lifetime risk of colorectal cancer ranges from 40 to 70% for the patient with Lynch syndrome, significantly exceeding that of general population. The Lynch syndrome related to colorectal cancer tend to occur in younger age group. Median age or at the diagnosis is 40 years approximately, and arise mostly in the right side of the colon. The increasing rate of distal colon cancer among individuals under the age of 50 is high, and above the age of 50, proximal colonic cancer were raised according to literature. Now, the mortality colorectal cancer is fourth more common cause of the cancer-provoked death in young adults. ASER data analysis between 2000 to 2014 demonstrated that the increase of 13% in the colorectal mortality rate among patient age 20 to 49 years. And the mortality among the adult age group who were more than 50 years of age declined by 34%. So it is increasing in young patients. Hereditary polyposis colorectal cancer is an autosomal dominant and is a phenotypic result of the defect in the mismatch protein repair protein system. As you all know, this mismatch repair protein genes normally produce protein that identify and correct the sequence mismatch and that may occur during DNA replication. Hereditary polyposis occurs in two types, the Lynch syndrome 1 and the Lynch syndrome 2. Lynch syndrome 1 is familial colonic cancer, and the Lynch syndrome 2, along with colonic cancer, other systems were also involved, mostly reproductive systems such as endometrial, ovarian, stomach, or other cancer of GI, and malignant neoplasm of small bowel, hepatobiliary, pancreas, and upper urinary, prostate, brain, and skin cancers. And MMR gene lead to accumulation of cell mutation. These are the cell mutation which mostly occurred, and in which MSI showed 27 to 35% risk of developing cancer in young adults. MLH1 and MSH2 showed 60 to 80% cancer formation risk in young adults. MSI ranging from 17 up to 17% in general population, and there is no specific biological marker for young adults colorectal cancer apart from MSI, which is associated with Lynch syndrome. And colorectal cancer non-polyposis associated colorectal cancer in young adults arise from pre-existing discrete proximal right-sided colonic flat adenomas mostly. In Lynch syndrome, the carcinogenetic process much more rapidly progress in 2 to 3 years in comparison with sporadic adenomas, which occurred in 8 to 10 years. An estimated risk of developing metacutaneous tumor is 30 to 40% within 10 years and 50% within 15 years, and which is decreased in general population, like 3% risk in 10 years and 5% risk in 15 years, but it increasing when patient has Lynch syndrome. Mostly, these are the etiological risk factors which causes early increase in carcinogenesis in young patients. Environmental lifestyle contributions include lifestyle habits such as eating red meat consumption and sedentary lifestyle, the consumption of fast food, obesity, type 2 diabetes mellitus, and metabolic syndrome and smoking. Crohn and ulcerative colitis both risk in setting of those colitis. Some studies shows that the obesity is a major risk factor for colorectal cancer in men and to a lesser extent in women. Obesity has to be proven to be a stronger risk for colorectal cancer in premenstrual women as compared to postmenopausal women. And analysis of national cancer database showed that the African American race and Hispanic ethnicity, low household income, and low education are the independent negative predictors for overall survival for colorectal cancer in young population, which compared with cohort of individual of 60 years of age. So this is also like low household income and low education. These factors are also present in our population, which contribute to a early rectal cancer in our population also. So, and both SEER data and National Cancer Database show that the early onset colorectal cancer present with more involvement in regional lymph node, distant site at the distant metastasis or distant site at the site or time of diagnosis, stage 3 or 4 at the time of diagnosis, which are also present in our data. Larger tumor size, more than 5 centimeter, and high risk of perineural infiltration, lymphovascular invasion, and signet cell or mucinous type of histopathology. These all factors are involved. High aggressive disease and uh, uh, advanced stage at the time of presentation. So we need to uh, develop some screening protocols or for the early detection of the disease and prevent improve the mortality and prognosis. So the guidelines for the prevention and early detection of colorectal cancer, there are established screening guidelines. Adhering to these guidelines remains low despite the national effort to improve the screening rates in our population also. This recommendation to screen individual with a family history who present with sporadic rectal colorectal cancer are typically missed by these screening. Because of the poor screening in the young age, these people are often identified by only develop colon cancer in early life. American Society of Cancer established an update to their guideline and lowering the recommended screening age to 45 based on the result of the microsimulation data at both the individual and population level. Screening colonoscopy should initiate 10 years before the age of diagnosis of the youngest affected relative or at 40 years, whichever comes first in patient who has individual with family history of advanced adenoma, colorectal cancer in first degree relative before the age of 60 years, and first degree relative to first degree relative at any age. So these are the recommendation at which we start screening in general population if we found these risk factors. High-risk screening indications in hereditary syndrome, inflammatory bowel disease, family history, and improve capture of family history and real life adherence to risk-based screening guidelines are the area that need major improvement to reduce the early onset rectal cancer and morbidity and mortality because of this cancer. Initiating colonoscopic screening at the age of 45 versus age 50 increased lifetime gain, life years gained by 6.2% at the cost of 17% more colonoscopy per thousand adults over an individual lifetimes of screening. So if we found the patient at the time of diagnosis reactive to symptoms and delays, prompt workup of symptoms, identify germline predispositions and family history. And for the treatment, advanced stage disease, coordinated multidisciplinary care is needed. Personalized and state-of-art expert care is needed. For stewardship, multiple life domain impacted, tailored age-specific holistic care, committed care for diagnosis for long-term stewardship. Prevention, highest the risk factors unknown or unrecognized, adherence to screening guidelines in this setting, and awareness and modification of risk factors we needed most. The whole physician committee should involve in the awareness, dissemination of the screening information to increase the population awareness, sign and symptom of disease, screening practices, recommended guidelines. Screening of general population with symptomatology, the scientific committee should discover and develop good biological and molecular marker for early diagnosis. The cost-effective method for universally screening of Lynch syndrome, microinstability, microsatellite instability, and immunohistochemical evaluation for expression of key mismatch repair protein. And expertise in clinical genetics, advanced multidisciplinary team coordination, comprehensive attention, long-term stewardship is needed to prevent or early diagnosis of this early colorectal cancer so that we can do a curative surgery if the patient has symptoms or early cancer, and improve the prognosis and decrease the mortality. So as a whole, we need to sit and discover the guidelines and the awareness session for the symptomatology of the early rectal cancer, and the early symptoms, the bleeding PR, or the findings at the in proctoscopy or colonoscopy, like the sessile polyp or any adenomas or any polyp, pedunculated polyp, we need to screen and uh, put patient in close follow-up, so decrease the progression or progression of the disease, and early diagnosis of the cancer in young patient. And we need to discover some cases, like in our setup we don't have genetics. So we need to develop some centers which do the genetic study for the early colorectal cancer, so that their family members should screen and strictly follow the guidelines to prevent the early colorectal cancer progression in their family. And increase the awareness program, like we are doing the breast cancer awareness every year in the month of October. So we need to develop some screening programs or the dedicated for the colorectal cancer, so that the awareness in the general population increases and they present earlier for their symptoms at the early stage of the disease. And also we need to work on our genetics and immunohistochemistry for these sporadic type of colorectal cancer which diagnosed early in the disease. We have limited data at this moment, but we are planning to do a long-term follow-up and recurrence and all these things including our study in future. And this is just for a thought के we need to लाइक कि अब हम कोशिश करेंगे प्लीज हम इस पे भी सोचना शुरू करें, और हम लोग जो है अपनी अवेयरनेस सेशन और अर्ली क्लोनोस्कोपी एंड सिम्टोमेटोलॉजी को वो करें टू डिक्रीज दिस progression of early onset colorectal cancer which are coming in aggressive stage of disease. Thank you so much.
Thank you very much, Dr. Nazia, for such an in-depth insight into this increasingly challenging disease, especially in the young. Like I said before, we'll gather up the questions and deal with them towards the end. The next presentation will be delivered by myself live. Um, this has essentially this is essentially a general reflection on inspired by an emerging need to apply basic biomedical principles in the day to day clinical practice. I shall first try to create a context for the topic and present its expanding scope. We shall then try to explore how, if at all, we may begin to base our clinical practices on the already established but also forever expanding body of knowledge that is the basic medical sciences, and finally reflect on the limitations of just such an approach. So, the prime objective of translational medicine is to bridge the gap between knowledge gained at three levels of medical research: the bench side, the bedside, and the community. Now, we know that most of clinical research is conducted either at the bedside or the community, but there is a wide compendium of research which is done at the bedside in the laboratory, which probably takes years to materialize into clinical practice. The purpose of translational medicine is to translate, as it says, this knowledge into clinical practical application, to somewhat reduce the duration that it takes for this knowledge to reach the practicing clinician. In this regard, I love to quote this phrase, the valley of death, to denote all the basic research, basic science research, which gets lost into void and never sees, so to speak, the light of day in terms of its clinical application. There are several reasons for this. Partly, our newfound obsession with seeking the evidence only through clinical trials, but also the widening gulf between the basic scientist and the clinician. The translational medicine provides a platform where this bridge, where this gap, this chasm can be bridged meaningfully, and the basic science research conducted in the laboratory can find its way into the clinician's desk earlier and lead to a meaningful, more scientific application um, at the bedside as well as in the community. A very related problem is the somewhat inordinate emphasis on subspecialization. Narrowing it to our context, the discipline of surgery has proliferated over the past 5 decades into several superspecialties. And today's specialist is really expected to know more and more about less and less. Mind you, I'm not against subspecialization or super specialization, but you must agree with me that one consequence of just such an approach is that the clinician, he or she, loses the holistic and the basic scientific perspective in in the clinical practice, in the day-to-day clinical activities. It is interesting to note that how these two indisputable overlords of the general surgery continue to define our speciality, where a general surgeon, like the definition of the Canadian Association of General Surgeons, is expected to know a wide range is expected to be aware of a wide range of the body of knowledge. And there is an altogether forceful stress on a comprehensive knowledge base spanning across almost all basic science specialities. You can see it mentions not just anatomy, but also intensive care, immunology, metabolism, nutrition, pathology. That's an altogether very expansive body of knowledge that at least our speciality, or somebody aspiring to become a general surgeon should be knowing. Needless to say that such an understanding is not possible without keeping oneself abreast of the current bench-side research. There is already a very broad spectrum of basic science knowledge that anyone who enters clinical practice is already supposed to have acquired in the medical school and maybe even later on in the research context. But to think that everything in these specialities, such as anatomy, pathology, physiology, has already been done and dusted, I think it's a profound misconception. And you could do it on your own. Literature search on the kind of bench side research that is contributing towards an expansion of knowledge in these biomedical domains. Such insights have engendered the inspiring concept of the surgeon scientist, like the two thought provoking definitions that you see here, where he studies and questions the scientific basis for the patient's disease, not just the evidence base, that is important, one must admit, but he is also expected to ask meaningful questions that would guide, steer the bench-side research. When he identifies the problem at the bedside, takes these problems to a laboratory bench side, finds the solution, and brings it back to the bedside. I believe the need to keep the basic scientific spirit alive is slowly and steadily taking root in the psyche of a majority of institutions of repute. Um, like we see here, where dedicated departments for translational medicine to coordinate between the bench side scientist and the clinician, or even to provide the clinician with a platform to conduct bench side research, have been created and are funded in sizable budgets on a yearly basis. You can also see that there are several master's programs offered to the practicing clinician, not just to hone up his research skills, but also to grasp the significance of keeping oneself connected to the bench side research model when one is a practicing clinician. There are several dividends to be harvested of just such an approach. By keeping this spirit of inquiry, this scientific spirit alive, we can annul this label of technocratic addicts, which we have come to own with a bit of pride, I must add. And not just that, but also we can improve our understanding of the disease process without simply resorting to our technical skills of already established paradigms of surgical care. It also broadens the possibility of research in the surgical discipline. Quite often, we struggle with trying to come up with meaningful questions that can be translated into robust research models. Now, every person practicing in the surgical discipline would certainly see the point that conducting a randomized control trial or even a large size case control study can be particularly challenging in the surgical discipline. And in this context, to give you an example, we often struggle with what research topics or themes we can help our trainees to take up, where it's a necessity for their current training requirements by the College of Physicians Surgeons. In this context, I think access to bench-side research models and bench-side research, even animal or vet research, can be a significant dividend of institutionalizing a translational approach towards surgical practice. But by far, the most significant benefit which can be gained of a translational and a basic biomedical approach to surgical practice is what is depicted in this picture, where medicine yesterday was primarily a symptom and an intuition based practice. Today, we are established in an evidence based protocols and evidence based paradigms. What one aspires for is the precision medicine of tomorrow, and that's the thing of the future. Not only will it be algorithm based, that's underestimating a very broad meaning of precision medicine. It expects the clinician to know at the molecular, or if you may allow me some bellicose statement, a subatomic understanding of the pathogenesis, the etiogenesis, as well as the treatment protocols of the disease. I don't see why surgeons should not be an integral part of this new revolution in the practice of medicine at large. And I think it is high time that, on behalf of our specialty, I would say that we should start preparing ourselves towards this precision based model, a significant, a very important aspect of which would be to rediscover our lost association with this scientific benchside and laboratory models of research. However, such an approach is not without its downside. Knowledge of the human body in health and disease is nothing short of a big bang. It is too easy to go down the slippery slope and lose the human touch, as you can see uh, in the caricature on your right. And that will be altogether too disastrous for the patient care. Molecularizing uh, human contact, which is the essence of clinical practice, is one will only indulge in such an approach at one's own peril. So the human connection in all this scientific realization has to be kept alive as well. And this would probably be the other extreme in contrast to the current trends of technical specialization, where I develop a morbid association with a group of molecules, thinking those are the alpha and the omega of clinical practice. One has to continue to stay holistic and humane, while at the same time continuing to go deeper and deeper into our understanding and comprehension of disease processes and treatment paradigms. I conclude that translational research and biomedical sciences are going to define the precision medicine of tomorrow, of the future. And I strongly exhort that the surgeon of tomorrow trains himself or herself for benchside and basic biomedical model in order to not become redundant when it comes to whatever will define the surgical practice a few decades from down the road. So the surgical discipline needs to keep the scientist inside, the scientific spirit alive. And I say, like I said before, to rediscover, because I strongly believe that their spirit got lost somewhat in the past, when we obsessed ourselves with the technical, the skill portion of their speciality. And the real thing would be to find the right balance, especially when it comes to training and teaching, where the scientist of the surgeon of tomorrow is not only a scientist but also a human being when it comes to giving the human touch to the clinical practice. Thank you. Um, we move on to the next presentation. Um, a very important problem in abdominoperineal excision of rectum, somewhat related to what Dr. Nazia was talking about in terms of the disease that we'll be talking about, is a very important problem. In fact, the Achilles heel of abdominoperineal excision of rectum is perineal wound failure. Dr. Aisha Parveen is a first year resident in the general surgical discipline, and she'll be presenting on factors associated with perineal wound failure after abdominoperineal excision of rectum.
Dr. Aisha Parveen, and I'm a resident in General Surgery Department. Thanks to the ICON 2022 for providing the platform as a speaker. And in this session, I will cover the topic of perineal wound failure after abdominal perineal excision for rectal cancer. First of all, briefly, we will discuss the global burden of the colorectal cancer, as it is the third most common malignancy and the second most deadly cancer. It poses a significant global burden. We can see very clearly in this pie chart presentation that the incidence of the colorectal cancer is around 10%, and the mortality that is caused by this cancer is around 9.3%. Moving forward, in the management of rectal cancer, we must recognize that even at its most significant, surgery is primarily a craft with a very special challenges and rewards for excellence. Current investigations in the rectal cancer management are developing paradigm, and they emphasize the minimally invasive surgeries, the minimal invasive options, the less radical resections, and even the organ preservation. The options available for this are the two that I've mentioned, the transanal endoscopic microsurgery and the low anterior dissection, the both of which are the sphincter preserving surgery. But undoubtedly, there remains a population of the patient who remains APE, that is abdominoperineal excision, in whom the best oncological outcome cannot be achieved without APE. And this is the first operation that is described by Sir Andrew Smile in the 20th century, at the beginning of 20th century. In general, the APR is reserved for the patient with a low rectal cancer, in whom the sphincter preservation is not an option. The options for the surgical approach of abdominal perineal excision are basically depends on the anatomical tissue plane. The basic concept is that the resection should target the tissue plane outside the tumor margin in order to achieve the R0 resection or the margin negative resection. And there are various variations, the intersphincteric variation, the extralevator approach, and the istioanal variation. All of these are based on this concept. Here I'm presenting this slide, and the basic aim to present this is that we have clearly seen the tissue planes for the different variations of abdominal perineal excision, and in which you can see very clearly the intersphincteric variation will create the narrowest perineal wound, and whereas the istioanal variation is the widest of the perineal dissection. So the more wider that dissection, the more chances of the perineal wound failure. Even at best, AP has the potential for significant morbidity. The most significant source of morbidity is the perineal wound. The rate of perineal wound failure vary among different studies, and it is as high as 40%. Why this failure pose a significant morbidity? This poses a significant morbidity in terms of prolonged hospitalization, hospital readmissions, home nursing wound care need, delay in adjuvant therapy, and expenditure of the significant medical cost. To assess the factors associated with perineal wound failure after AP, we did the retrospective analysis of the case series of patients who underwent AP for rectal cancer from January 2015 till May 2021 at the Indus Hospital, Karachi. The associated factors we included in our study are uncontrolled comorbid conditions like hypertension, diabetes mellitus, and poor nutritional status in terms of hypoalbuminemia, neoadjuvant radiation therapy, and of course, the stage of the tumor itself. The primary endpoint was perineal wound failure. A total of 19 patients underwent abdominal perineal excision from Jan 2015 till May 2021 at the Indus Hospital, Karachi, and all of them were enrolled in study. No one is excluded. The data collected from HMI's outpatient and inpatient medical record. They divided in two groups, the group A and B, on the basis of perineal wound failure. In group A, in which the there is a perineal wound failure, we can see very clearly that 1/4 of the patient has hypoalbuminemia and other comorbid conditions like hypertension and diabetes mellitus. But we can see, while in a group B, we couldn't find any comorbid condition except hypertension. In patients who had perineal wound failure, 87% of the patients had received the neoadjuvant radiotherapy. But on contrary, all the patients in other group received the radiation, which is contradictory to our original hypothesis that the radiation contributes to perineal wound failure. For stage, one would expect majority of the patients who are operated for advanced malignancy or with positive resection margin, a larger proportion should have perineal wound failure. However, our data indicates that as being as 50% of the patient with early stage tumor, means stage 0, 1, and 2, has perineal wound failure, and which is comparable to only 33% of the patient with advanced stage disease who do not develop the wound failure. In our study, the rate of perineal wound failure was found to be 42%. Among the patient characteristic, the age group that is affected by rectal cancer is young. Protein deficiency reflected by hypoalbuminemia contributes to reduced collagen formation and wound dehiscence and result in poor wound healing rate. No doubt, hypoalbuminemia is a risk factor for the perineal wound failure in our study, and it is approved in our previous studies as well. It is unknown whether the early administration of albumin will improve perineal wound healing after AP, but improving the patient nutritional status before surgery will certainly benefit the wound healing. Further clinical trials are needed to evaluate the efficacy of reducing the incidence of perineal wound failure by correcting the albumin level before abdominal perineal excision. As a result of such an extensive morbidity that is associated with abdominal perineal excision, the indication for surgery has been debated over the past several decades. And the most recent evidence is coming from Brazil, the study that is done by Ammarah Ghani. He strongly emphasized the policy of expectant management in a patient with complete clinical response following the neoadjuvant treatment. He compared the patients with complete clinical response with complete pathological response, and he reported the no difference in terms of overall and the disease-free survival. The watch and wait strategy of Ammarah Ghani strongly emphasized that the meticulous assessment at least 8 weeks from the completion of the chemoradiotherapy may identify the subsets of the patient that may be safely managed conservatively by observation alone. The adoption of this strategy will avoid the significant risk of post-operative complications. Previous studies in literature suggested that the radiotherapy was a major risk factor for the perineal wound failure. The ultimate result of perineal radiation therapy is fibrosis, and that ultimately leads to delayed wound healing. In our study, the radiotherapy had a non-significant tendency for perineal wound failure. As we discussed before, the reason for this may be the proportion of the patient that undergoing radiotherapy was relatively high. Although radiotherapy likely contributes to perineal wound failure, its almost routine use did not allow for the meaningful comparison between the patients with and without neoadjuvant radiotherapy. A cautious review of the literature as well as the current number indicates that the role of radiation as an etiological factor in causing the perineal wound failure is at best hypothetical and conjectural. There is no hard evidence to support, though there is biological evidence. There are certain limitations to our study, as the sample size is very short and it was a retrospective study. And at best, we cannot proclaim that the same technical strategy was applied because we have 3 operating surgeons in the faculty. So we cannot assess the technique-related cause of perineal wound failure. Finally, perineal wound failure is considered as at least heel of abdominal perineal excision and is enough to spoil the result of good operation even when one achieves the negative margins or the R0 resection. In order to address this, there is a need to conduct a prospective or a retrospective large sample size cohort study to assess the risk factor or the reasons for this morbidity. Thank you so much.
Thank you very much, Dr. Aisha Parveen. There is an expanding category of so-called borderline tumors, which fall somewhere between the malignant and the benign variety. Dr. Muhammad Abdullah is a second-year resident in general surgery, and he'll be presenting his insight, his research into Phyllodes tumor of the breast.
In the name of Allah, the most compassionate, the most merciful. Assalamu alaikum and good morning. I am Dr. Abdullah, postgraduate general surgery trainee at the Indus Hospital, Karachi. As you can see on the screen, our topic today is the spectrum of Phyllodes tumor of breast regarding its epidemiology and biology, in which we included some data of our own population diagnosed with it. Starting with a little bit of background about breast cancers, in 2012, it was estimated that about 1.7 million new cases per year of breast neoplasms were reported in the entire world. And it is predicted that it will increase by 25% in the years to come, making it the second most cancer. According to a WHO report in 2015, the incidence rate of the breast cancer ranges from 19.4 per 100,000 cases people in East Africa to 89.7 per 100,000 people in the West Europe. Pakistan shows the highest reported incidence of the breast cancers in Asia, except Israel, as per the available literature. Furthermore, highest rate of the breast cancer in Karachi is observed in comparison to the rest of the Asian population. The mean age of breast cancer in Pakistan is more than 49 years, which is less as compared to the Western societies, where the mean age is around 54 years. According to Shafat Khana Memorial Cancer Hospital and Research Center, 20-year data extending from December 1994 to December 2014, breast cancer is the most common type of cancer among the Pakistani females. Now, the various forms of breast neoplasia exist, in which a cystosarcoma Phyllodes constitutes a rare form that represents less than 1% of the breast cancers and 2.3% of all the fibroepithelial breast neoplasia. This neoplasm is manifested in the women of all ages, including adolescents and the elderly, with majority ranging from 35 to 54 years. Multiple studies have been conducted during the recent years concerning the comprehension of biological behavior of the fibrosis tumor. So moving forward, there are significant caveats in the knowledge base of fibrosis tumor vis-a-vis epidemiology, biology, clinical features, and prognosis. So here we intend to evaluate the relationship among the various factors to help solve the puzzle in our population. Now, a little bit of the introduction. Cystosarcoma phyloides is a unique fibroepithelial tumor, and it was first described by Johannes Müller in 1838, who coined the term cystosarcoma phyloides, and it is a misleading description as majority of these cases follows a benign clinical course. Histologically, it has been subclassified as benign, borderline, and malignant, and the majority of phyloides tumor have been described as benign, that is around 35 to 64%, with the remainder divided between the borderline and the malignant subtypes. So grossly saying, it is a solid mass with this well circumscribed or well-defined margins within the normal breast parenchyma, and usually ranges from 1 centimeter to around 50 centimeters. Here we can see there are the cystic areas. These are the cystic areas in the tumor mass, as the name indicates. However, phyloides part will be described later. It is shown in this. It is not shown in this picture, but there are foci of necrosis and hemorrhage in the large tumors. Regarding the epidemiology, usually considered a variant of fibroadenoma, cystosarcoma phyloides is a rare type of breast cancer representing 0.3 to 0.5% of total diagnosis. And because of the rarity of cystosarcoma phyloides, little is known about the epidemiologic features of the disease. There are not many population-based studies have been published over the years. One study published in ISRN surgery revealed that the women aged between 35 and 55 years are commonly involved, and a case review conducted in the Greece revealed an incidence of 22 cases with a mean age of 38 years between 1968 to 2007. Now moving towards the patient of our population, we took all the patients from 2017 to 2021 diagnosed with phyloides tumor and studied them in a retrospective manner. Of the risk factors, there are no conclusive risk factors between the diagnosis of cystosarcoma phyloides and other variables as a risk factor. However, we have strived to delineate a potential association between cystosarcoma phyloides and variables such as age, history of prior pregnancy, breastfeeding, and menopause. The age range from 20 to 56 years, with the mean age of cystosarcoma phyloides is 35.25 in our population. Most of our population, that is around 75%, has a history of prior pregnancy. Lactation, pregnancy, and increased estrogen activity occasionally have been implicated as a factor stimulating in the tumor growth. However, exact correlation is not defined yet. Speaking regarding the breastfeeding, majority of our patients have a history of breastfeeding. And there is no significant relation between histopathologic subtypes of the phyloides tumor and menopausal status. However, majority of our patients were at the childbearing age. Now, the diagnostic modalities, there are 5 criteria that we took in account for the diagnosis of phyloides tumor. Although mammography and ultrasonography are generally important in diagnosis of breast lesions, they are notoriously unreliable in diagnosing cystosarcoma phyloides. This is because the mammography appearance of the cystosarcoma phyloides as a round density with smooth borders is quite similar with the fibroadenoma. Moreover, magnetic resonance imaging MRI has not been well studied. Hence, finding of the MRI in the cystosarcoma phyloides are not definitely diagnostic. And fine needle aspiration cytology is usually inadequate for the diagnosis of cystosarcoma phyloides. So we neither attempted for MRI nor the FNAC for the diagnosis of phyloides tumor in our population. Core biopsy and open excisional biopsy are generally more reliable, but sampling errors may still occur, and it still may be difficult in differentiating the cystosarcoma fibroides with the fibroadenoma. So it remains the cornerstone of the diagnosis of fibroides tumor. Now, speaking regarding the pathobiology, fibroides tumor are biphasic tumor histologically characterized by a leaf-like architecture resulting from an enhanced intracanalicular growth pattern, cleft-like spaces lined by epithelium, and hypercellular stroma. Usually, benign forms of cystosarcoma fibroides demonstrate increase in the number of regular fusiform fibroblasts in the stroma. However, it is very occasional that high anaplastic cells with any old changes are observed. And however, in the malignant form, a high degree of cellular atypia with the increased stromal cellularity and an increased mitotic count is almost always observed. Ultrastructurally, nucleoli may reveal a coarse mesh nucleolema and abundant cisternae in the endoplasmic reticulum, which is true for both benign and the malignant forms of cystosarcoma fibroides. Now here we can see the WHO classification, WHO criteria to define the histologic subtypes based on the stromal overgrowth and atypia, stromal cellularity, mitosis, and tumor margins. And we can see that all the parameters have significant value to fall in the malignant subtypes. A microscopic slide of the fibroides tumor is showing stromal overgrowth and stromal cellularity, and we can clearly see a leaf-like projections as the name fibroides indicates. So this is the leaf-like patterns. A more magnified image clearly shows two different components of the tumor. So this is the epithelium. This is the epithelial component, and this is the hypertrophied hyperplastic matrix or stroma. The epithelial component of these tumors are usually benign. So 18 of our population were diagnosed as a benign fibroides tumor. One of them was borderline, and the remaining 5 were malignant. So the treatment options: surgical management is the mainstay of treatment. However, type of surgery has been a matter of debate over the years. Despite high in the incidence of the local recurrence in wide local excision, studies have shown no difference between the wide local excision and mastectomy in terms of metastasis-free survival or overall survival. If diagnosed preoperatively, tumor should be resected with at least 1 centimeter margins, particularly in the borderline and malignant types of the fibroides tumor. Hence, the decision regarding the lumpectomy or mastectomy depends on the size of lesion. For benign forms of the cystosarcoma fibroides diagnosed after local excisions, wait and watch policy should be applied. Whether patients with the benign fibroides who have undergone wide local excision and have histologically positive margins should undergo further surgery is controversial. However, re-excision of borderline and malignant fibroides should be considered. However, re-excision of the borderline and the malignant cystosarcoma fibroides identified after local excision should be considered. The adjuvant therapy. The use of radiotherapy and chemotherapy is controversial, but as per the available literature, adjuvant radiotherapy found to be beneficial in the patients with adverse features, example, bulky tumors, close or positive surgical margins, hypercellular stroma, high nuclear pleomorphism, high mitotic weight, and the presence of necrosis. Chemotherapy including anthracyclines, ifosfamide, cisplatin, and etoposide has been mentioned in the various studies, but with no survival benefit. Now the recurrence. Local recurrence rates ranges from 10 to 40%. It appears to be related to the extent of the initial surgery and should be regarded as a failure of primary surgical treatment. In the multivariate studies, the surgical margins is found to be the only independent predictive factors for the local recurrence. In most patients, local recurrence is isolated and is not associated with the development of distinct metastasis. Three of our patients has local recurrence, out of which one has metastatic disease. Now, moving towards the conclusion, cystosarcoma phyloides is a rare breast neoplasm which exists in the different histopathological subtypes and has no defined epidemiology or risk factors. Surgical wide local excision is the mainstay of treatment. However, disease tumor-free margins must be achieved to avoid the recurrence. Once the tumor recurs, then it must be re-excised and adjuvant radiotherapy attempted if it requires. Sample of my study, the limitations of my studies are it is a prospective study design with a small sample size and it is based on a simple center in a single center. So these are the references of my literature review. Thank you.
Thank you very much, Dr. Abdullah. May I request all the online audience to kindly type in their questions in the Q&A section so we can manage them towards the end of the session. An extremely important aspect of clinical practice is how we reach out to our patients. And more, the outcome of clinical practice is based on the input from our customers, the patients themselves. Dr. Shahzad is a second-year resident in general surgery, and he'll present a survey on patient satisfaction after the first encounter in the surgical clinics. Dr. Shahzad.
The most merciful and most beneficent. I am Dr. Shahzad at the Indus Hospital. As you can see, the topic of presentation is patient satisfaction with patient-physician communication in a surgical outpatient department. As you know, the patient will never care how much you know until they know how much you care by Terry Tinal. Introduction. As you can know, the patient-physician relationship is a complex psychosocial interplay of vulnerability, trust, and authority in a professional setting. If trust is the defining element of patient-physician relationship, then communication is the means to engender trust. Effective communication improves patient and physician satisfaction and thus clinical outcome, and is perceived as the extent their perception and exceptions have been met. According to a survey, about 75% of surgeons believe that they had communicated satisfactorily with their patient, but only 21% of the patient expressed satisfaction with their surgeon's communication skills. Literature review reveals lack of objective methods to assess this important aspect of the healthcare services. But the objective of our study is to objectively assess patient satisfaction at first encounter in surgical outpatient in a tertiary care hospital, for which we adopted a tool from the Royal College of Family Physicians, which comprises of socio-demographic information and 11 individual questions. The social demographic information includes age, gender, marital status, education, employment status, and general information about the health. And the 11 individual questions include about making feel at ease, letting you tell your story, really listen, and the list goes on. However, each individual question had 7 options ranging from poor to fair to outstanding. We did a cross-sectional study with a non-probability convenient sampling from October 2021 to December 2021. The sample size was calculated to be 139 patients. The inclusion criteria were age above 18 years and participants who gave consent and the one who visit OPD for any reason at the first encounter. The N was calculated to be 139, and the data was calculated by intervening individuals on a validated tool by Royal College of Family Physicians, as I showed you before. And all responses was tabulated and analyzed using SPSS version. As you can see, it is a pilot study. We only run this on 37 patients. The N was 37. It shows the most of the patients who visited our outpatient department were female, of age between 30 years till 50 years. Mostly were unmarried with the background of low socioeconomic class. Majority of them had a chronic disease, while the frequency of hypertension and diabetes were increased as compared to the other chronic disease. We analyze the data by using only frequency and every chart. The percentage of satisfied and unsatisfied patient at each scale was calculated. As you can see, the most of the patients were felt at ease, and they assured that they were heard during their first encounter, and more than 80% of the patients were assured that the doctor has showed compassion and care, and he has been positive in attitude toward them, and he helped them in making a plan of action with them. As a conclusion, the majority of the patients who attended the outpatient department was satisfied from the communication of doctors. As you can see, our data set is very small to come to our conclusion. We propose that patient-physician communication tools should be used to assess patient satisfaction. These will allow objective assessment of an important competency of effective communication, especially for surgical trainees. This objective evidence can be used as a criteria for appraisal and promotions.
Thank you, Dr. Shahzad Asif. Our last presentation will be presented by second-year resident Dr. Ammarah Ghani. A lot of elective surgeries get to be postponed for several reasons, and this has become an epidemic in its own right over the past 2 years for obvious reasons. Dr. Ammarah Ghani is going to present the reasons for elective surgery postponement at the Indus Hospital, Karachi.
Currently working as a general surgery resident here at Indus Hospital. I am genuinely thankful to the ICON 2022 sixth final conference beyond the call of duty for allowing me to be a part of it. I'm here to present a small study, postponement of elective surgery, how and why. Indus Hospital in Healthcare Network is a non-profitable organization and performing surgeries free of cost for the past 15 years now, alhamdulillah and mashallah. Which means that we have to cater a huge number of patients, most of whom belong to the low socioeconomic class, and they travel from far-flung areas just to be operated here. Formulating an arrangement of an elective surgical list, it's a resource-intensive process involving the whole system and the usage of manpower, which involves use of surgeons, the anesthetists, the theatre technicians, as well as the housekeeping staff, the nurses, and resources, the operation theatre, sterilized instruments, the outpatient encounters, inpatient admissions, the pre-operative risk assessment and optimization of the patients. But at times, depending on the magnitude of the surgical operation, either there's a brief or a prolonged inpatient admission, a pre-operative risk assessment and proper optimization of the patient is required, which actually adds a further strain to the already burdened system. However, postponement of surgeries, it's an ongoing problem. It's in most of the high-level medical facilities, and it has got a substantial impact on the patients accumulator with potentially negative consequences at times for the healthcare systems. Like any other healthcare system, we cannot ensure a cent-to-cent output with the pre-scheduled operations, which engenders a sense of disappointment on part of the patients and is responsible for the loss of confidence in the public sector for the healthcare providers. In addition, it also leads to the increased waitlist time for the elective list, which is one of the myriad problems faced by us as we have to struggle to manage and to accommodate all these patients. And it also affects the patients in different manners. The objective of our study was the unanticipated postponement on the day of surgery, which is a tremendous emotional and economical trauma for the patients as they have to travel from far-flung areas to cause an increase in the operation theatre cost and decreases the efficiency as well. So this study was performed solely in order to assess the rate of postponement of the elective cases on the operation day and to evaluate the causes of such postponement, which in turn would help us in figuring out certain workable solutions for it. The National Healthcare Service, UK, through its modernization agency theatre program, identified case postponement as an incidence that occurs after the patient has been notified for the operation. Any efficient surgical service should have a low rate of postponement, but if it's increases, it's actually the efficiency is jeopardized, the wait list is increased, the frustration is increased. So we just did a study to find out if we could help this in any way. A retrospective chart review of all elective surgical lists of the Department of General Surgery was done for the months of August, September, and October 2021. And the records were reviewed through HMIS from the EMR department of our hospital. The data that we find out was the total surgery that we planned were 816, out of which 64%, 524 were performed, and 36%, 292 were postponed. The reasons that were documented in our EMR for the postponement were 11% were postponed because the patient came out to be COVID positive, and 26% came out they postponed because the patient did not undergo COVID testing. We'll come in a while of why this is important and why this is necessary to undergo the testing. A major chunk, 44%, were postponed because of the time constraints, and 12% were because of the patient-related factors. Either the patient did not follow or they refused for surgery for multiple causes. And 7% were postponed because of the medical reasons. Either the patient was unfit for anesthesia, had high blood pressure, upper respiratory tract infection, or cardiac issues. It is usually thought that the medical reasons would be a major cause for the postponement of the surgeries, but in our study, we found out that it's because of the time constraints. So this is how it is. We can see that 44% is because of the time-related issues. We have a goal of taking appropriate steps that will have an impact on the avoidable factors for postponing the elective cases to reduce the wastage of hospital resources and to enhance utilization of operating rooms, increase the patient satisfaction level, which is our motto, which is of what we are being taught as a training, that the utmost importance is the patient satisfaction level. COVID, the emerging challenge to surgical practice. The COVID-19 pandemic, as we all know, has led to a major disruption of the routine hospital services globally. And during this pandemic, hospitals have made a policy of making COVID PCR negative documented COVID PCR tests at least 72 hours prior to the elective surgery. And this is solely in the interest of the patients and the medical personnel because of the fear of exposure and the desire to reassure the patients that the hospital areas of our hospital are COVID-free. This is just to implement the universal safety precautions, and this mandatory COVID testing is being done. According to the literature sources, according to the studies that have been done previously, and according to our study, we found out that the most common cause of case cancellation on the day of surgery was because of the lack of time to perform surgery. 44% cancellations fell into this category, and the main reason that we found out were because of the addition of emergent or semi-emergent aggressions, including the cases of malignancy, as we cater patients of surgeries that are the surgeries are time consuming, and they often at times become very emergent. So we need to postpone the cases that are elective and make space for them. Loss of OR space and unannounced holidays. We have certain recommendations in order to counter this problem, that in order to avoid the postponement of surgical lists, we could have one thing that could be done was we could have imperative specific slots for specific surgical domains like upper GI, the lower GI, and hernia. Since in a general surgery department, we perform surgeries from the whole GI tract in the OR that are being allotted to us only. We have 5 ORs, and they are being shared by other subspecialties: peds surgery, urology, orthopedics, plastic surgery, ENT, as well as gynae as well. So it's being shared by numerous subspecialties. So there could one thing be if we just specify or dedicate certain slots, but currently our system does not permit this. And another drawback is that we do not have a dedicated operating room or a surgical team, which could be only used for the patients that require emergency surgery, because at times, whenever there's an emergency, we have to give up or postpone, delay our elective list so that we could entertain the emergency surgery. Another recommendation is if we schedule much less surgeries than the anticipated time slots, but that would lead to thinning out of the list and loss of patients' operating time. Another thing is that this should be, it's just a point that we performed this study during the months that were not to peak for the COVID, and we had already cleared our backlog of the surgeries that were during the COVID peak area. era in the 2020 and in the start of the 2021. So during this time, the months that we conducted this study, normal elective lists were being undergone. The 26% of our cases were postponed because the patient did not follow for surgery, or the patient refused for the COVID test. So a patient's decision not to undergo surgery is also an avoidable cause, given that a better preoperative preparation of the patient should be done, like a more adequate and a more detailed conversation with the patient prior to establishing the indication of surgery and admitting them to the ward could lower the number of cancelled elective cases, giving them specific time and a more detailed and to answering all the questions on the OPD in the OPDs. So when we book the patient for the surgery should be done. It's a little difficult since we have to get a huge number of OPD patients, a huge number of patients needs to be seen in the OPD, but if you just spend a few extra minutes to counsel them adequately for that, especially counseling them regarding the importance and the procedure of the COVID testing and its benefit for the patient. This is there are certain patients who refuse for the COVID testing because they think that it may harm them, or the procedure is painful or dangerous for them. So if we just explain in detail or give certain moments to tell them how the test is being done through different manners, either showing them a video of how the COVID testing is being done, or sending them to the personnel that are performing the test, so that they have an idea of how it is done and are not being afraid of getting it done. Unforeseen anesthetic or the medical problems also delay the planned list. However, the condition of the patient, if it has acutely worsened before the surgical procedure, like increase in the blood pressure or the upper respiratory tract infection, they are the common etiologies that are being followed. And often at times we cannot do anything regarding that. But there is one thing. The preoperative risk assessment can be undertaken at multiple levels. A mandatory preoperative risk assessment at the time of admission for the patients and for the inpatient admissions, and mandatory risk assessment 24 to 48 hours before admission in day case surgeries. We could implement or introduce a 3-level model for risk assessment and stratification by anesthesiology, by the surgery, by the hospitalist. So the pre-operative risk assessment should start from the moment the patient is being reviewed in the OPD or in the ER if we are booking a patient for an elective case, by finding out the reason that could lead to the postponement of the surgery, and then catering it accordingly. There's another recommendation that an Indus hospital and healthcare network is a vast and expanding network that could increase its OR space by volunteering to utilize the public sector facilities or partnering up with them to utilize their underutilized sources, such as the nearby government or the semi-government setups that we have in our region, in our area overhead, which are performing just 2 to 3 surgeries per day. And rest of the time, the ORs are not being used, and all these ORs are well camped, having good facilities. If we could just think about it and try to utilize their facilities till we get the expansion building that we have, that would definitely increase our facility, our number of the patients and the number of the surgeries as well. And in addition, the staff could also play an important role in identifying the cause, as in the hypertension. If the staff is going to find out the patient has got high blood pressure, they could inform us beforehand, and that could cater the problem beforehand. If there is any other recommendation, any other hand, you're more than welcome to listen to it, because at the end of the day, all what we want to do is to increase the efficiency of our system, of our healthcare system, and benefit as many people as possible. Based on the results of our study, we came to the conclusion that the percentage of elective cases postponed on the day of surgery could be lowered with a better preoperative preparation in terms of the psychological state of the patient, the diagnosis of the disease, a more rational surgical schedule, a better planning of surgical procedures, and better utilization of the operating rooms as well as the medical staff could be done, implementing the recommendations that we just had. A smaller percentage of cancelled elective cases Smaller the cost of hospital, better utilization of the operating rooms, and higher the satisfaction of the patients, which contributes to the higher quality of our healthcare services. Thank you for your time. I hope you have a good day. Thank you.
Thank you very much, Dr. Ammarah Ghani. Those were some very unorthodox recommendations coming from you. And we start the Q&A session. And I can only see one question here. If I may request the esteemed audience once again that if you want to pose a question, kindly write it down in the Q&A session and I'll bring it up. We get our panel of 6 speakers, excluding myself, 7, including myself, to come online so we can start with the Q&A session.
मैं बैठा था
Okay. Once again, Dr. Ghina had proposed a question. Apparently, it was a question proposed to me of whether I would propose genetic experts and molecular biologists to be a part of multidisciplinary tumor board. It seems quite a bit relevant to Dr. Nazia's talk, and she has also answered it. And I'll read out her answer in a while. But since it has been posed to me, for my part, relevant to my theme, the one that I presented, I would go a step further and say that I would want to have a closer coordination with the genetic experts, the molecular biologists. In fact, biomedical scientists, those who are biomedical scientists by vocation, I would want to have a coordination with them at all levels, not just at one or two meetings or platforms. And that is, in essence, of what I am proposing when I say that biomedical sciences and translational medicine has to be made an integral part of the surgical clinical practice as well as the surgical training programs. Okay. You're online. I want to. I have a question for Dr. Aisha Parveen. I have a question for Dr. Aisha Parveen. Why did you consider radiation as a risk factor ab initio in your research question? If Dr. Aisha Parveen can answer this. Why did you consider radiation as a risk factor to start off with? Dr. Aisha, yes, Dr. Aisha.
Yes, I'm online. Radiation cause ischemic changes and hello.
We can hear you,
Yes,
Dr. Aisha.
radiation.
Go on.
Radiation cause ischemic changes.
Dr. Aisha, if you can reduce the number of people who are in the room with you right now, the voice quality is going to improve. That's what the coordinator tells me, at least. Yes, Dr. Aisha. Okay, if Dr. Abdullah is online, I have a question for Dr. Abdullah as well. So, given an opportunity to define the biology of Phyllodes tumor, what would be your preferred area of research that you would choose? Would it be clinical or would it be biomedical aspect of research? Dr. Abdullah. Request Dr. Abdullah to put on his mic. Yes, Dr. Abdullah.
But I would rather suggest to go for the genetics of the disease. Gen-
When it comes to genetics, what would be, do you have any proposed model of research of what would it be the basic, the very basic genetics of the tumor itself, or would you want to explore the next generation sequencing? Thank you very much, Dr. Abdullah. Once again, I am grateful to we are grateful to the organizers of ICON 2022 for providing us with this learning great opportunity, and we are especially grateful also to all the speakers who took out time to get their presentations recorded. Have a good day.